Yanni, you can join now. Oh, come back.
Recording in progress. 45 minutes at 3 o'clock, body camera video captured the heart-stopping intense time. See the moment of quick thinking technique. There's an unconscious that and more on Repeat 25 News.
You get it down to be caught on what Tommy do.
Yeah, it's actually a taken kid, and this adorable rest of the herd and getting our first checkup. Cherokee taken are a rare species, making them vulnerable to extinction. How cute. They're well adapted to cold and high altitude.
Hi, everyone. If we can just make sure that everybody is on mute other than Dr. Ganguly, please. Thank you. So Dr. Ganguly, you're the host now, so you can go ahead and put your presentation up.
Okay, thank you. Can you hear me okay?
Yes.
Am I too loud? Which I'm
No.
always anyway.
It's good.
Let me see if I can share the screen because, okay, hold on. Somehow I cannot, hold on. See. Let me see if I escape from here. For some reason, I don't know why I can't minimize this. Let's see. should be good at it, but it's almost a few years that we have been doing this.
Your camera? No.
Can you guys see my screen? I doubt.
We can't see the screen right now.
Okay, hold on. I know what's going on wrong here. Okay, I think now I can share the screen. Let's see. What about now? Can you see my screen?
Yes.
Okay, good. So again, another year, another same Ganguly talking about stroke. So nothing new about that. But unfortunately, all of us are kind of, we have to do this for certification. So when there's, you have to do it, kind of, let's go through it. Let me make it a little bit. Okay. So I think it's the same thing, and all throughout the year, there will be six webinars regarding this. But the reason that we have these seminars is that stroke is a devastating thing, although it has come down from the 5th leading cause of death to 4th leading cause of death, but stroke carries a significant disability. And people who have dealt with stroke patients over the years, they know that it becomes a social disease. It's not necessarily that the patient cannot now walk or talk, but then someone has to be around that patient because they're either falling, they're tripping, they are down on the ground for a long time without no one around them. And definitely as a human being, you lose a lot of your human abilities. So it's 800,000 strokes a year. It's a huge problem. And every 30 to 40 seconds, we have a stroke occurring in this country. And as we talked about, that 50% of the people only get back their function, 20% are institutionalized for 3 months, and it becomes a social disability, period. I think someone's mic is on, and pardon the interruption, as they say, but could you, Jerica, could you, I have to do it, I guess, right? Someone's mic is on.
Everyone, can you please
any.
mute yourself, please? Thank you.
Okay. So why does it matter? Because in a stroke, about 2 million brain cells are dying each minute. The person who's having a small stroke versus a person who's having a large stroke, all of which the time is of essence. The faster the stroke, the faster we can get to an intervention, the risk of disability goes down. So that makes a difference between a person being in an institution versus being independent in their daily activities of daily living. So we start with a case in most of the, and this is a case of a patient who came in with a history of hypertension, diabetes, hyperlipidemia, coronary disease, congestive heart failure. And around 9:30 p.m., all of a sudden, patient becomes unresponsive. Patient's nurse comes in to evaluate the patient, and they call in a code stroke. The vitals are 199/70, a little elevated, but not that bad. Pulse is around 68 per minute, and it's irregular. Patient cannot respond, cannot follow command, just stares at the nurse, occasionally moaning, gaze deviated to the left and cannot look to the right. And there is a right facial weakness and moving the left side, but nothing on the right side. And the glucose check is 106, and you can see the labs in the morning were all normal. So even if you didn't attend this lecture, I'm sure that all of you would say, well, someone who's not talking and not moving one side is a stroke until proven otherwise. So we have a way for people who are not in nursing, even for common people. You can have someone in the market or someone you're seeing in the park. If they're having any of these symptoms, that's a sign of a stroke, and we should call 911. This person is already in the hospital, so we don't have to call 911, but these are the signs that we look for. If there's a balance issue, if their eyes are affected, either they can see one side or they see double vision. If there's a droopiness of the face of one side, and if there is an arm weakness, along with speech difficulty, then you call 911, which is the time. So we have a mnemonic called BFAST, where you cover most of the aspects. The balance of the eyes are more related to the posterior circulation strokes, whereas the rest are all the anterior circulation strokes. So this is the CT scan. And many of you who have gone through these lectures for the last 8 years have been familiar with the CT scan. This is the skull. And as these are the area of the orbits, you can see this is the midbrain, and this is your right brain, this is the left brain. And here,
Dr. Ganguly, the slides are not moving over.
Oh, What about now?
No, not yet.
What's going on?
Only your first slide.
Okay, let me go out then from the first. It's moving over for me. I don't know why. Okay, I don't know what's going on here. Let me see.
There we
So
go.
is it maybe it's in the is it now? What about now?
Now
Can you
it's
see?
Now it's working.
Okay, so
yeah.
we start again, right? But it will be fast this time. So 800,000 strokes a year. Every 40 seconds we have a stroke. It's a huge social problem because it becomes social disease. 50% only gain functional independence, so the next 50% are it cannot, so they need either help or some devices to help them work, and 20% are institutionalized. 2 million cells dying every minute. And we start with the case where someone who came into the hospital with hypertension, hyperlipidemia, and around 9:30 p.m., patient became unresponsive. Nurse called a core stroke, and we talked about the signs that they are not able to talk, and the gaze is deviated to the left, right side is not moving, right face is not moving, and the glucose check is good, and the labs in the morning has been good. There is an irregular pulse going on. And we talked about the BFAST, which is the balance, eyes, face, arms, speech, and time. Now, balance as eyes are mostly for posterior circulation stroke. Eyes means that either they are seeing double vision or they're not seeing anything in their vision. That's a significant disability. And face, arm, and speech, and anything affected on the same side, definitely then we need to call 911 or time. Or in this case, the nurse already called a core stroke. So this is the CT scan, which was done within 10 minutes. As you can see, this is the skull. This is the midbrain, which is the Mickey Mouse, M for M. And inside, anything white is blood until proven otherwise. You don't see any white. However, you see this rope-like structure, which is white. And that we'll talk about it later, what that is. So everyone's so interested in doing NIH stroke scale, so we should be somewhat familiar with it. And I see all the nurses running to me that, why did you take out that order for doing an NIH stroke scale? So it is like, you can't go anywhere in the hospital because I'm all barraged that, why did you stop, this patient from getting NIHSS, which, as you know, is really the other way. People want to know, why do we have to do the NIHSS? And I always say it's good to practice. So the first thing in NIHSS is the level of consciousness, because NIHSS is equal to the EKG of the cardiologist. And brain is such a diverse and a vital structure with so many functions going on. So now EKG takes you like a second to do it, but this is the EKG which tells you what part of the brain is working and what part is not working. But the first thing is that, is the person even conscious? So that's the first part of this test. And so we have the level of consciousness, and everyone in this line should have their NIHSS done, and you can get 3 hours of CME from that. So I would recommend you to do it. There are the 3 points: either the patient is alert, keenly responsive, or not alert and arousable with minor stimulation to obey, answer, or respond, and not alert at all, and repeated stimulation needs to be done, or the patient is having reflex like decerebrate or decorticate posturing and unresponsive. 1B involves that, okay, the patient is alert, but is the patient following commands? So you ask them the month and how old are you? If they can answer all these questions, you score 0. If they cannot answer one of them, you take 1 point each. Now you look into whether the patient is able to follow your commands. Like, they could answer the questions, but open and close your eyes. So you need to understand, and then you need to do that act. And that's what you're checking through this part of the test. If they can do both the tests correctly, you score 0. If they cannot do one, then you score 1. Remember, when you do a grip and release, try to do in the one which is not the weak arm, because the weak arm, the person cannot be able to do it. Through the first test, you pretty much check the whole brain, because your level of consciousness is your midbrain. So you check that. Then you are telling them to follow a command, or you ask them your question of how old are you, or what month is this? You check the temporal lobe, and then you ask them to understand your question and answer and act accordingly. Well, you checked pretty much your temporal lobe, and then your parietal lobe, and then eventually your frontal lobe. So you're checking pretty much the whole brain through these few questions. Next thing we check is a visual field. So as you know, this is the occipital lobe, which is the green. That checks our vision. We are mostly so we have 2 visual fields: the median and the lateral, or what we say as the median and the temporal. And if people can see and no visual loss, then we say 0. The rest is and the rest is that if there's a partial hemianopia, it's 1. If there's a complete hemianopia, it's 2. And if the patient is bilateral hemianopia, we call it 3. So what does that mean? So in this diagram, as you can see, this is the eye. This is the right eye. This is the left eye. So half of this eye is going and crossing to this side. The other half of this eye is going to the same side. So as a result, if the person has a occipital lobe problem, then this half of the eye is not seeing, because the other side also has a cross connection. So we have what we say as a homonymous heminopsia. That means half of the field is lost, but it's on the same side. Excuse me. But on the other hand, if it's a pituitary problem, then people have hemianopia on their lateral side. It's like the horses with shades. So they're looking only straight ahead, like a tunnel vision. But if people can also have strokes in their eyes only, when they have complete loss of vision in one eye, but the other eye looks normal. This is not, whenever you see this type of pattern, that one side the person says, I'm right eye is completely blind, it is never the brain. Because brain problems are always homonymous. It has to be both sides. Left visual field on my left eye and left visual field on my right eye. So both of them has to be homonymous. Anything which is not homonymous is not the brain. It's either the pituitary or the eye itself. So this is how a homonymous heminopsia looks. So you can see this is the full picture. This is how they look. They can't see this part of the picture. Next thing we look for is gaze. As you know, there are 6 gazes, 6 cardinal gazes we have. However, in the NIH stroke score, we only check for the horizontal gaze. And so we are checking at this and this. And as you know, that the gaze is connected by 6 different muscles. So we have a lateral gaze, we have a medial gaze, we have an up gaze, down gaze, and then there's rotational gazes. But the one which we check are mostly the lateral gaze or horizontal gaze to the right and to the left. And to do that, you need 2 main nerves to work. As you know, we have 6 muscles, which are, so the lateral rectus pulls the eye on the right eye to the right side. The medial rectus pulls the left eye to the right, and vice versa. But there is a connection between the lateral rectus. So the lateral rectus is connected by 6th nerve. The medial rectus is connected by the 3rd nerve. There is a connection between the lateral and the medial rectus, which is called the medial longitudinal fasciculus. And whenever there is a problem in this part, in this L-shaped structure, that's when people see double. And that's where people have double vision. And people with double vision, although they can still move their eyes in the horizontal plane, they still see double, and that's disabling. So in most of the cases, they may not have anything, and your NIH stroke score may be 0, but double vision is a disabling deficit. And I have given thrombolytics to people with double vision after taking the risk benefit and alternatives. Next comes facial palsy. As many of you know, that these whenever you see this, that the side which you're pulling the mouth, as well as the side which you can bring the eyebrows up, that's the side which is normal. The other side is abnormal. And if you have a normal symmetrical movements, you don't score. If it is a minor paralysis, it's 1. If it's major, that you are like this person, it's 2. If the upper part is involved, when we say it's a Bell's palsy, that's the time we say 3. So in the next cartoon, you can see why it is that if someone is having a stroke, they spared the top or the forehead, but if someone's having a Bell's palsy, they will have half of that forehead involved. And this is the reason. So this is the same side, and this is the contralateral side. As you can see, the facial nerve, the upper part of the forehead, is supplied by the contralateral side as well as the ipsilateral side. So that's the reason the upper part of the facial muscles are spared in a stroke. But the lower part of the facial muscles are supplied by the contralateral. The green, which is coming from the other side, is coming down and crossing over and supplying the lower part. The black, which is coming from the same side, goes down and then supplies the top part. So because the stroke is happening on this side, people have control of the upper part, but not the lower part. And that's how you distinguish between a Bell's palsy and a person with having a stroke. And whenever there's a Bell's palsy, this is where the problem is. So the whole side gets involved, not only the lower part of the face. This is the next example. As you can see, that here you can see the wrinkles are here. The person is lifting the left eye, and you can see the wrinkles, but it's all flat here. And the level of this eyebrow is lower compared to this. Also, the face is being pulled on this side. The palpable fissures are much more prominent here than not that prominent here. So this person, the NIHSS stroke score is 1, 2, 2 for here and 1 for here, 3 in total. What about this problem? You can see that, and people who follow Hollywood news, that she had a Bell's palsy before. And because of the Bell's palsy, you can see she tilts her head because this is the side which is the abnormal side. Because you can see the prominence here, you can see the eyes are much smaller on this side, which is a normal size. You can see the eye size is a little bit prominent. And so that's the reason to counter that. She tilts her head to the side so you don't see that much of asymmetry. What about the motor exam? The motor exam, we generally check the right upper extremity, right lower extremity, and followed by left upper extremity, left lower extremity. And this is your motor cortex. So as you know, we are all crossed. So if you have the weakness, this is the area to get involved. This is your sensory cortex. So generally, you check for the motor function of the legs and the arms. You see for a drift. If there is a drift, but it starts drifting when you count to 10 in the upper extremity or 5 on the lower extremity, but it does not touch the bed or it does not go down, then you score as a drift. And but on the other hand, it goes down and touches, but still patient is able to lift it, then you score a 2. And if there's no effort, you lift it up and immediately drops, that's the 3. And if the person cannot even shrug the shoulders or move the proximal part of the muscle, then it's a 4. And same thing with the arms also. And there is an example here. So you can see this person is drifting, but still able to maintain some drift. So this is something which we will say somewhere around 2, because they can't hold it till it's completely reached in the down. Limb ataxia, that's the finger to nose or the heel to knee. That's always the cerebellum. That's what we are checking. And whenever you do that, although you can see this is the trick, that you cannot do it very close, because it's very close, you won't be able to pick up the ataxia. And that's the reason sometimes when we see that patients' upper extremities, you don't get the ataxia because someone did it very, very close, but the lower extremities, you find the ataxia because it's very difficult to compensate for lower extremity ataxia. And as in this example, as you can see, that you have to at least keep the finger in a distance that you can extend it. And depending, next is sensory. The sensory is mostly contralateral in most of the places. So when I get a pinch on the right side of my arm, it generally crosses over and to the spinal thalamic tract, goes to the thalamus, from where it goes to the cortex, and that tells me that there's a mosquito in my arm, and I either move my arm or I have the other arm try to get rid of it. So many patients you will see, and if it's no sensory loss, you say 0. If it's mild, you say 1. If it's severe, you say 2. And that's where many patients will only have sensory problems because the thalamus was affected. So they have hemisensory loss, and they have a significant of burning and tingling on the entire right side of the entire side of the body, which got the stroke for years. So that's the reason it's important. Although the patient has sensory loss, sometimes it depends on how disabling it is. And that's where the risk benefit and alternatives come in. This is again your sensory, this is your motor cortex, this is your sensory cortex. As you can see, these cortices supply different parts of the body. This is the lip part, this is the face part, the fingers, the hands, the trunk, and the feet. So that's how your distribution is. And then we come into language. You give them the language card and you try to see what they are seeing and what they're doing. Some people, when they'll have neglect, they won't completely not talk about the lady with the water spillage, they will only talk about this. Similarly, if it's the other side of the brain, they will only talk about the lady and not talk about this. And this is the time when you pick up the fluency of the speech. This is a time when you make sure that the naming is correct. And then you do the naming card and try to tell them what these things are. And they will try to say, and that's how you categorize 1, 2, and 3. And this is your speech circuit. So this is your what we say as the Wernicke's area, where after hearing we know what it is what people are asking us to do, and then you send the signal to the Broca's area, and from the Broca's area you speak using your tongue and your muscles of enunciation. This is a PET scan. As you can see, this person was repeating whatever the examiner asked him or her to do. So because when you have to listen to something, the auditory cortex lights up, which is the green, and this is the primary auditory cortex. Then it goes to the Wernicke's area to make sure that you understand what the command was. And then depending on that, then they want to repeat the things. That's where your Broca's area fired. And these are the areas of the muscles of the tongue that lights up. So that's how the whole repetition is. This is a person who's reading. The occipital cortex lights up. It sends the reflex to the Broca's area, and the Broca's area eventually understands what you're reading and then starts reading accordingly. So that's how the speech circuit is. Then there are other organs of your speech, like your tongue, your muscles of palate, which are muscles of enunciation. And that is not controlled by the cortex, that's mostly controlled by the brainstem. And if there is a brainstem stroke, that's where people become very dysarthric. And these are the things that have been told, or that have been requested to repeat, so that you bring up any dysarthria in the person. So mama, mama, tip top. You see the T, the ta. Those are the things. If there's a dysarthria, you can't avoid that. It's when tip top, pipty pipty. Those are the pangs. So that's a baseball player. So these are made in such a way that you have to use your tongue more and your enunciation more. And if there is a subtleness in that, that will be picked up. And lastly, the extinction and the inattention, which generally comes from the parietal lobe. So for example, if someone is having a parietal lobe stroke, then they may completely neglect that entire side. So if they sometimes don't even know whose hand is this. So you put their left hand up, they say, yeah, my hand. Whose hand is this? They have no clue. Or even when you touch them, they feel the left side. When they touch them, they feel the right side. When you do them both together, they say the left, because there's an extinction which happens on the contralateral side. This is mostly picked up when people have right parietal stroke. As I tell people all the time, that NIHSS stroke score is heavily favors the left brain, not the right brain. So people who are Democratic people, it will be easier to pick up their stroke than the Republican people, because the right brain is not well represented, which is, I think, there should be a way that we should be balanced, but it is not. Because left brain is our main function, our speech, our understanding, and everything. So the National Institute of Scale, it has a total of 42. The lower it is, the better. The higher it is, the worse. So mild symptoms are generally thought to be within 5. But remember, if it's a complete Heminopsia, it's around 2. So that's a significant problem. If I can't see the right side, I won't be able to drive or maintain my activities of daily living. Similarly, severe aphasia is around 2, which is again a problem. So lower score does not mean it's not disabling. Lower score is just lower score. Similarly, visual symptoms are only 1. Any weakness against sustained effort, that's where, these are the disabling symptoms, that although the scores are low, but you can't stand up if you have a slight drift on your right leg, because you won't be able to walk because you'll keep on falling. Anything which is large vessel, we generally see 6 and above, but now it's more like 10 and above. But even in Beverly, we have seen patients coming in with like 2 or 3 and had a clot sitting in the internal carotid artery, which was just causing minimal symptoms. So stroke scales are helpful, but scales don't decide whether the patient needs treatment or not. And I know everyone is excited to do the NIH stroke scale, but I believe that at the end of the shift, NIH stroke score should be done by the person who is going out and the person coming in. So at least you know what the score is, rather than getting a surprise in the middle of the night. So for that patient who was in the DOU, and now we have this person who's not moving one side and not really talking with a gaze deviation. So what are the common possibilities? It could be hypoglycemia. It could be TORS paralysis. Subarachnoid hemorrhage can present with altered sensorium. Migraines can present with altered sensorium. Mass lesions like tumors or abscesses can present it. Or if the patient had previous history of anything, like a previous stroke and now it got worse, or if hypertensive encephalopathy means you're altered, and if that's a possibility, conversion reaction is a possibility that people are faking, in other words, and vestibulopathy. However, in our case, other than stroke, let's look into all this thing. I gave you a thing which says 106 was the glucose. So you know this is not hypoglycemia. Patient never had seizures. So it's unusual that the patient has seizures and is not moving one side and not talking, but kind of moaning. Subarachnoid hemorrhage is mostly patients are already in a coma or altered. He's awake, he cannot talk, our patient. Migraine patients don't have gaze deviation. They can have weakness, numbness on one side of the body. Even migraines can have strokes, but generally they don't have gaze deviation. You already saw the CT, so there was no mass lesion. Reactivation of prior deficit, you never got a story that he had a previous stroke. So whatever is happening is new. His blood pressure is a little bit on the higher side, but not to the point of 220, 240. And conversion reaction, to have a conversion reaction that person needs to be a neurologist, because he's gaze deviated to one side and weak on the other side. That's not someone who can, without knowing how the brain works, can do a conversion reaction. And definitely it's not a vestibulopathy, which is the dizziness, because he's not dizzy, he's not complaining of dizziness. So as everything in medicine, the most important thing is the history. It's part of your most important evaluation. What was it before? When did it start? What was the last well-known time? That's what we go by. And depending on that, we decide on the tempo of the process. If the last well-known time is within the last 4.5 hours or even 6 hours, we say it's acute. If it is more than that, we can say acute still because it's been the 24 hours. Anything after 24 hours, we say subacute. And if it's more than 6 weeks of duration, we say chronic. However, some people may have a chronic thing. For example, someone was a mild stroke before and had a mild weakness, and now all of a sudden got worse in the last 4.5 hours. Well, that's an acute on chronic. So that's how we determine what the tempo of the process is. And depending on that, we divide these into different baskets. So what the first basket is, this is an acute neurological deficit. Someone who was, normal, all of a sudden is not normal. So that's an acute neurological change. And when you have an acute neurological deficit or an acute neurological change, the first category is, okay, if the person is awake or the person is altered. If the person is altered, that means you are not getting the history like this guy. Is this focal or non-focal? You say, well, he's altered. How do I know it's focal or non-focal, right? So if the person is altered and you do a sternal rub really hard, don't feel bad of giving pain. Pain is the constant nociceptive stimulus which everyone responds. So if you really do a sternal rub and you see that the person is moving both hands towards that pain, you know that both sides are moving correctly. Or if you see that and one side is moving and the other side is not moving, well, you can give a little painful in the nail bed and see that the other side is also withdrawing. Then you know it's focal or non-focal. In this person, if it is focal, that means not moving one side, or it could be moving all sides together but altered. The other possibility is that the acute neurological deficit happened, like in our case, patient is awake, but it's a focal deficit. He's not moving one side. When you have these situations, if it is a non-focal thing and sudden onset, the few things that you think of are, is it metabolic? Like if the person's vitals are good, did we give any medication of maybe a half an hour ago? Is the sugar good? Is the person having any seizures? And strokes are a possibility also, but those are the first few things that we want to rule out. On the other hand, sorry, this is not the one which I wanted. So on the other hand, let me go back to that. On the other hand, if it's a focal deficit and the person is awake, it's stroke until proven otherwise. So I don't want to delay on this because I think we'll be running out of time, but let's go over the individual mimics. So hypoglycemia. Patients with hypoglycemia will be altered. They can have generalized weakness or focal weakness, and that's one of the reasons that we check in your code stroke orders. We have a glucose check, as well as in your BMP, there's a glucose check. Many patients with hypoglycemia can have gaze deviated, like because they have seizures. They can have seizures, but the key is that the blood glucose is low. And yes, there can be a history of, history that the patient did not eat and then got something, or there can be a sweating, but sweating is not always true, as you know, that people with, when they're diabetic for a long time, or if they're on beta blockers and stuff, that sweating doesn't always occur, and similar thing with tachycardia. But the key element is that blood glucose is low, and if you correct the blood glucose, so if someone's blood glucose is 40, and you correct that, and they start moving everything and talking and stuff, that's good. In the next 10, 15 minutes, if they still are not moving, and you recheck the sugar, and now it is 230, and the person is still having the deficit, that's again a stroke until proven otherwise. Because the good thing about glucose is, because brain goes by two main things. Brain doesn't care about what you're eating or how you look. It goes by two different things. One is glucose, the other one is oxygen. If and when the glucose comes in, brain immediately gets back to where it is. So hypoglycemia should be corrected immediately in 15, 20 minutes. If it's not corrected, you are still thinking this is a stroke. It was just a coincidence that the person also happened to have hypoglycemia. What about metabolic issues? So the metabolic issues you look for is definitely hypoglycemia, any meds we gave, mostly any narcotics. And many patients with narcotics, if they are on kidney failure and stuff, they slowly accumulate, and then in the first, second, third dose, nothing happened. The fourth dose you gave, and patient went into a complete obtunded state because he has been accumulating and his kidney functions or liver function is not good enough, and now he responds like this. Low oxygen or high carbon dioxide. So if someone has a obesity and obesity hypoventilation, or they have sleep apnea, and now you gave a medication like a benzo or a narcotic, they lowered their respiratory drive, their PCO2 rises up, and immediately they go into a hypercapnic respiratory failure, they're obtunded. But these are the people who will be obtunded, but they will be moving all their extremities, or they are not focal in their exam. Low blood pressure can also cause obtundation because brain needs some blood to flow, because if that's the reason that people pass out, is that when you stand up and the blood has to go up, and if there's a low blood pressure, the back of the brain is not getting the blood, immediately the brain will reflexly pass you out, because when you pass out, people fall, and when they fall, all the pressure is in the same level and they regain their consciousness. So that's how the more important cause of syncope is. And as I tell all of them, that syncope is always a cardiac issue rather than neurological issue. And then we talked about the BUN and creatinine, which can sometimes cause problems. And mostly if you give medications to renal patients, they can be obtunded, and we have to be careful about that. What about seizures? Definitely it's sudden onset. People can have sudden onset seizure, which many times it is witnessed. And many of our stroke patients are, as you know, are on monitors. So if there's a seizure going on, the monitor will look weird. It may look like there's a VTAC going on or something. Many people have a history of seizures, so you know that this may be a seizure, and it could be what we say is a torse paralysis. After a seizure, one person is not moving one side, but the gaze deviation gives into this. When there is a seizure, for example, the left brain is causing the seizure, so generally the person is deviated, eyes are deviated to the right, the head is deviated to the right, and when they have the seizure on the right upper extremity, which eventually becomes weak. So there are two things which causes the eyes to deviate to the side of the weakness. One is seizure, the other one is a Pontine stroke. So these are the two main things that causes the deviation of the eye to the same side of the weakness. The rest of all the strokes, the deviation of the eyes is opposite to the side of the weakness, as you saw in our case. What about migraines? Migraines can cause stroke-like symptoms, and migraines can cause strokes. Migraines are vascular phenomena. It's a spreading depression. So it comes on from one side of the brain that the spreading depression starts, and then which results in vasoconstriction of the arteries. That's where people see simmering lights. That's where people can see half side of the body. That's the time when some people will say, "I'm numb on the right side of the body." All of these suggest that there is some visual, some vascular phenomena going. And then eventually, when the vessels dilate, that's when people have the throbbing headache. So that's the phenomenon of the migraine. And as you can see in this patient, this is cerebral blood flow. And you can see that one side of the blood flow, which is the left side, is completely gone. This person is having a migraine. But with time, it goes on to the right side. So it starts from the left side, and now as you go through these images, it eventually ends up on the right side. So this is something which is a spreading depression, we say, but migraines sometimes can cause strokes, and we have seen that. Actually, there are some nurses who have been following over the years who presented to the ER with migraine and some numbness on the right side, and the numbness got better. And the migraine got better when we did an MRI, and there's a couple of dots of strokes in the posterior circulation. Migraine strokes are very common in the posterior circulation. What about mass lesions? Mass lesions, you should get a history that the person was not moving for the last 2 or 3 weeks, and then slowly, progressively getting worse. And in this case, you can see this is progressive neurodeficit rather than acute. This person, mainly this person had an abscess. As you can see, the abscess, an E. coli abscess. So this person was having headaches, nausea, vomiting for quite some time. And over the last 2 or 3 weeks, she was getting progressively worse to the point she started falling. And that's when she came to the ER, and the CT showed this. That's what we diagnosed her of having a cerebral abscess. What about exacerbation of previous deficits? So someone who has a big stroke like this, and now they have an UTI. So the big stroke, which caused them the weakness and the numbness on the entire right side of the body, now, and they are kind of getting a little better, maybe move a little bit. Now, all of a sudden, they have something like a UTI, or they have, they're given a medication for sedation. Immediately, their stroke symptoms get worse. Now, does that mean they are having a new stroke? Well, there's not much brain left here to have a new stroke. The whole left MCA is gone. So that's not a new stroke. But something we did, or the patient had a low blood pressure, or the patient had UTI, all of these can exacerbate old symptoms. And subarachnoid hemorrhage is not something that would cause generally focal symptoms, but it starts with the worst headache of your life, almost like a thunderclap headache. And then eventually you do, people go into a state of coma, pupils may be dilated one side or the other, and there could be focal weakness, but that's the last presentation. Generally, the focal weakness starts a few days after when they get into vasospasm and stuff, not at the beginning of the presentation. What about conversion? Like if someone's faking, that happens. You get you get something in social media. All of a sudden, you get all excited, and nowadays, and all of a sudden, you start having tingling and numbness in your left side, right? So it's like we have seen those people, but you can tell from their presentation that they're very, they're very high strung. They are maybe, or they are. You can feel the anxiety and the in their voices, and then, or someone maybe just having, what we say is functional neurological disorder. We then don't say conversion reaction anymore. And the functional neurological disorders, they're not moving one side. And you go in and you talk to them, and they're on the left hand, they're doing a social media. Well, if someone's not moving one side, and the other hand, they're using social media, well, that's a question, right? So that you would be worried that, oh my God, and mostly in a young person, that I'm not moving one side. And then you can see that they're faking like this, yeah, how long this is going on? Oh, for the last 2 hours, and but then when you go out, or when you came into the room, there wasn't that much of deficit. So immediately it kind of, the exam fluctuates. So sometimes you like put your hands up here, and then it's like, oh, going down and going up, going down, going up. So you know that if you can hold your hand here, most like the weakness is not there yet, and you keep on doing this multiple times. And there are bizarre symptoms. I mean, you say, like left eye is numb, and or left side of the head is numb. Now, you can have a numb head, but generally we don't, all the sensations are up in front, right? So, and you do the exam, and you do the tuning fork, and you hold, so they have a light midline discrimination, like right side is numb, left side is not numb. So you put the tuning fork and put there, yep, numb, 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 and then they start feeling it right from the midline. Now, the problem is they don't know that the whole forehead, when you do the tuning fork, it's not the sensation that goes to the nerves. It's the bone that transmits the sensation, and the bone cannot be numb. So when they say numb, numb, numb for the vibration, and then from the midline they start seeing, well, you immediately know that this person is not has functional neurological disorder. And lastly, definitely, the stroke is what we all look for. That's because we want to save people. 2 million neurons dying every minute. So this is sudden onset symptoms like this gentleman. There is a deficit. Either the vision is the problem, speech is the problem, or the person is having ataxia or cannot move one side. There's significant dysarthria or speech arrest. The gaze is deviated opposite to the side of the weakness. And there may or may not be headache, and there may or may not be loss of consciousness. So for when people you're not getting too much history, eyes are your best friend. And I know I show this, and people all yell at me because so I have to do this also for the rest of the population and whoever is online. So gaze is very important. Sustained gaze deviation, looking at the same side of the weakness, as I talked to you before. I used to say only seizures, but last week I had a patient who had this thing done 2 or 3 times, and I was taking the call at PIH, and the neurologist on call actually went and saw the patient, and she was weak on the left, on the right, and her gaze deviated on the right. That was hard, and then she got better. In another 10 minutes, she did the same thing. And all her studies were negative, including perfusion studies and stuff, but she was weak on the right side significantly. So we went and gave her TNK. We used TNK at Whittier Press. And this patient had a Pontine stroke. So in the literature, there is report of Pontine stroke causing gaze deviation to the same side of the weakness. So there are 2 things which causes gaze deviation. One is seizures or the Pontine stroke. On the other hand, if you're looking on the left side and right side is weak, that's mostly a stroke until proven otherwise. What about horizontal gaze? Sometimes, we have horizontal, like if there's a sustained horizontal gaze, This is called the sunsetting sound, which we used to call it in kids with hydrocephalus. This can also be seen in patients who has either hydrocephalus or a thalamic bleed. There are times when you have sustained upgaze. When this is happening, that's not a good sign. Looking up, where we are all looking up, right? So that's what it most likely tells. And I don't tell that to the family. But sustained upgaze is secondary to either seizures or there's an anoxic damage to the brain stem. What about localization? So if there's a left MCA going on, so left MCA should cause, the speech is affected, so both your understanding will be, so there will be an aphasia. Because the left side is involved, so the right side will be weak. And because the left side is also involved, the occipital lobe, the radiations are, so you will have a left homonymous heminopsia. Sorry, right homonymous heminopsia. So you'll have an aphasia, you will have a right hemiparesis, you'll have right hemisensory loss, you'll have a right homonymous heminopsia, and you have a left gaze preference. That's your left MCA. What about right MCA? You'll have a left hemi-neglect, because we talked about that neglect with during NIHSS. There will be a left hemiparesis, left hemisensory loss, and left visual field cart, and sometimes complete anosognosia or inability to say that there is a deficit. And these are the people who doesn't believe that they had a stroke, and that's the reason when they refused TPA, someone refuses TPA with a major stroke, you have to make sure that they are understanding it correctly, what the deficit is. What about the brainstem strokes? All the Ds together: dysarthria, dizziness, diplopia, dysphonia, and deafness. So when you see these 5 Ds, dysarthria, dizziness, diplopia, dysphonia. Dysphonia is that type of speech, and deafness, and there is a contralateral. So if the left side of the face is not working and the right side of the body is not working, that's a brainstem stroke until proven otherwise. What about the Lac Unit symptoms, the ones which are the small vessel strokes? We talked about the large vessel stroke with the brainstem as well as the MCA strokes. Generally, there are 3 or 4 types. One of them is the ataxia hemiparesis, so the little bit drift and they have ataxic. That's a small stroke. One is a pure motor hemiparesis. They can feel everything, but they can't move the face, arm, and leg. That's a pure motor hemiparesis. And then there is a sensory. They are numb on half of the body, and those people have just a midline numbness. That's the reason the person who's faking versus the person who is really numb, we have to distinguish sometimes. And then there's a thing called Disartry, clumsy hand syndrome, where you're dysarthric and your hands are not moving as fast as the other side. So these are all small vessel strokes, but they still can cause a significant amount of disability. And we all offer thrombolytics if they're if they're eligible and within the time window. The brainstem syndromes are interesting because, as we said, everything is contralateral. So if someone has a third nerve on the left side and right-sided weakness, that's a brainstem syndrome. If someone has a 7th nerve on the left side and right side, there's a thing called Millard-Gubner syndrome. And the dysarthria, if there's a hiccup, if you see there's a dysarthria, the dysphonia, the nasal speech, and the person is, when you hear that, and there's a little ptosis, that's a Wallenberg syndrome. Right there, even without a scan, you can tell this person is having a Wallenberg syndrome, which is the lateral medullary syndrome. Lateral part of the medulla is involved. So you can see this is a Pontine stroke. This is a locked-in syndrome where the person's pons is entirely gone. So this is a person who cannot do anything. They're quadriplegic. They just move their eyes, and that's pretty much it. Similarly, this is another Pontine stroke, which is only half of the brainstem is involved. But this is a Weber syndrome, which is the cranial nerve third is involved, and they're contralateral and they're weak on the other side. And this is the lateral medullary syndrome, which is the one with the hiccups. If you see someone who came in with a new onset of hiccups, and they are saying that I have problems swallowing and I can talk well, that's a stroke until proven otherwise. So let's look into some cases. So this is a 32-year-old with a history of a headache, double vision, and imbalance for the last 3 hours. So let's see if this works. So you can see on the left side, it goes all the way. Right side, it pulls down. And but as they look up, they can look up. And these how you see the nystagmus going on. Down, they can look, but then when they're trying to get up, they can't go up. So immediately you know. So in this video, you could see the nystagmus going on, the up gaze is limited, and there is a problem with when they move on one side, the other side pulls down. So this is, whenever you see this, that's a brainstem stroke until proven otherwise. So where is the problem? Let's see it again. You can see that. Okay. So this is where the problem was. Right across the, the lower part of the thalamus, that's where the thalamus and the upper part of the midbrain where the problem was. What about this person who is a 24-year-old with a history of depression and anxiety, all of a sudden had passed out in the party? Now, we said about conversion reaction. You remember, every conversion reaction happens in front of people. You don't want to do a conversion reaction when no one's watching, right? So it's always that there's something dramatic happening, and there's nothing else happening. Something happened, and they do it in front of people. As we say that, it's not like they're malingering or conversion. Nowadays we say, and we have ways to prove that these are functional neurological disorders. So let's look into this lady. So you can see there's a lot of people watching this lady, right? And you can see this lady is holding his hands, but from this thing you can say, well, it doesn't look like weird stroke symptoms, right? And a lot of eminent neurologists are in this room. Okay, this is Charcot, this is Babinski. You talk about the Babinski sign. So this is a person, Charcot is showing what happens when a person has hysteria. And you say, well, why did this person do this? You see this painting on the wall? This is the same caricature as this patient. So she's mimicking that. And that's interesting to know because that's how hysteria presents. You used to say hysteria, and this is first time Charcot described what hysteria is before even Freud and everyone started describing it. So what about this lady? 40-year-old with a history of double vision, again, D&D, double vision dysarthria, that came in over the last 4 weeks. Symptoms came in slowly. D&D is always related to brainstem. So let's see what's happening here. So it looks to the right, right goes, left doesn't go. Again, right goes, left doesn't go. And then looks to the left goes now, right doesn't go. Oh, that's interesting, right? So when she looks to the right side is going and the left side is not going. When she looks to the left, the right side is not going, the left is going, and she has this mild nystagmus on both sides. So she has what we say as INO, which means internuclear ophthalmoplegia. In the prior slides, I showed you a slide which is like an L shape, which is connecting the third nerve to the sixth nerve. That's exactly where her problem is. Now, this is going on for the last 4 weeks in a 40-year-old. So this is not stroke, this is MS. So that's where localizations help us more with these things. And this is exactly where she has the INO right by the side where the third nerve and the sixth nerve is connected. So going back to our case is that we have a 58-year-old who started at 9:30. You did the exam and it shows that the gaze is deviated to the left. There's the right facial weakness. They're spontaneously moving the left side, but the right side is weak. So right face, right side, and the left gaze is deviated. Glucose is normal, and patient is not responding. And there's an irregular stroke going on, pulse going on. So you already diagnosed it correctly that the person has a left dense MCA That's the reason the gaze is deviated to the left, and because the left side of the brain is affected, the right side is weak. And so that's and this was the diagnosis, and these were the things you're supposed to have. So you had to have aphasia, which he has right hemiparesis, which he has right hemisensory loss, he has a field cut, and there's a left gaze preference. And that's it for today. Any questions for me? I finished, in spite of starting a little late, 2 minutes earlier, 1.5 minutes. Any questions? I'm hearing someone's breathing pattern, so let me stop sharing the slide. Maybe that would be.
Okay.
I don't see Liliana not on the call, right? No, because we had a code stroke yesterday. So, and in the ICU, I wanted to.
Joy is here, doctor. I had a patient, doc.
Oh, you have the patient today?
Today, yeah.
How is he doing?
He still have like blurry vision on the left side.
Yeah, but he has that blurred vision for a long time. But he
on the right.
On the right, but the left side also he could count the fingers.
Yeah,
so
he can, but not on the right side of the left eye.
No, he could count the fingers everywhere. Because we checked it very thoroughly yesterday, and there was no field cut. The right side, yes, he has problem with the vision, and in fact, he was actually counting some of the right fingers too. But anyway, that person was not a candidate for thrombolytics anyway because of the platelets being down, and also the fact that if you have not a significant disabling deficit, the risk outweighs the benefit, because if you have a platelet problem. I have given GPA to people with less than 100, like around 98 or 94, but I disclosed to the family, and those people have significant deficits, like they are hemiplegic, they can't move completely. In that case, living like that versus taking a chance to have a bleed, knowing that the platelet is a little low, like in the low 90s, that makes sense. But if you're like 80s and stuff, and then you have a questionable deficit, then the benefit doesn't outweigh the risk.
Yeah, I agree, doc.
MRI is negative. Did you tell him?
Yeah, MRI is negative.
Well, your neurologist already told you that was not a stroke, right?
Yes, doctor.
So I mean, so I think I think that's the reason that I told you that I don't think that whatever is happening with him is new. I think that's going on. But what happened, I think what happened was his blood pressure. If you look at that time, the blood pressure was really low.
Low, yeah.
His blood pressure was in the 80s. So once you have someone with a vision problem and their blood pressure low, they immediately, the occipital lobes are not getting enough blood, and immediately they say, okay, this is a problem. And maybe that's what happened, what I thought. Because I checked him, like, he was not wearing his mask and I was wearing my mask, but I checked him really close with the fingers, and he was counting every finger correctly. So I think we took the right decision. I mean, he was not a candidate, but even if he was a candidate, I'm not sure that was a patient that I would have given TPA. Okay. Any other questions?
None.
Nope. Okay. I think we meet at the end of the month again with acute ischemic stroke, and that's the time we'll discuss about TPA, TNK, where we are with the stroke protocols, what are we doing more, all that stuff, all the fun stuff. Today's stuff was not that fun. It's boring.
It was a good review, doctor.
Oh, thank you.
Thank you, Dr. Ganguly.
When it comes from Roxanne, it makes my day.
Thank you, doctor. That's really sweet.
and that's the person I mean, she owes me a song again. She has to sing. He has to sing when I go in there, because when I'm down, that's when it lifts me up.
Okay, it's for
Thank
sure
you.
then, Doctor. Thank
Thank
you.
Thank
You're
you.
welcome.
Start singing now, Roxanne.